This is Dr. Diantha Vitant. I'm Professor of Dermatology at the Penn State University College of Medicine and also the President-elect of the American Acne and Rosacea Society. I have the pleasure of interviewing today Melanie Dispenza. Melanie is an MD PhD student in our laboratory here at Penn State, and she's working on determining the mechanism of action of isotretinoin. Welcome, Melanie.
Hi.
Can you tell me the title of your research project?
My project is titled The Immunomodulatory Effects of Isotretinoin in Patients in Vivo.
That sounds like a lot. So immunomodulatory effects. So does that mean that isotretinoin may affect the immune system or that retinoids affect the immune system?
Based on my research, that is true. The retinoids may be able to affect the immune system, or at least the immune system's response to certain pathogens.
So tell me a little bit more about retinoids in the immune system. Have these effects been observed anywhere else in the body?
Yes, there actually is a lot of research on retinoids in the immune system. The biggest, I think, field right now dealing with retinoids in the immune system is the induction of regulatory T cells. Regulatory T cells are actually immunosuppressive. They're T lymphocytes, but instead of inducing inflammation, they actually help to suppress immune responses, and so they will prevent autoimmunity or runaway immune responses.
So that's interesting. So if retinoids can affect the immune system, then why would you then want to look at isotretinoin in patients with acne? What was your idea there?
Well, what prompted that was that acne is, in a way, a reaction to P. acnes, which is a bacterium that lives in sebaceous glands. However, the paradox is almost everybody is colonized with P. acnes, but only some people get acne. So I was looking at acne as kind of a hypersensitivity to P. acnes. So I was wondering if maybe retinoids or isotretinoin reduced the reaction to P. acnes by the immune system in acne patients, and that maybe that was one of its mechanisms of action.
Hey, I read recently there's a couple papers that are pretty interesting. One paper in particular looked at acne patients and patients without acne, and they isolated their monocytes from the blood, and they found out that the acne patients, when the monocytes are stimulated with P. acnes, make more cytokines compared to people without acne. When their monocytes are stimulated, they don't make many cytokines. So is that what you're thinking then, that perhaps people with acne have differences in their immune reaction to P. acnes?
Exactly, that people with acne perhaps create a bigger inflammatory response to P. acnes than people who don't have acne, for example.
Well, that's interesting. So can you tell us how you did your study?
Well, I recruited acne patients who were scheduled to take isotretinoin for their acne, and I took blood samples from these patients at baseline or before they started their therapy, and then at different time points during their isotretinoin therapy. And from their blood samples, I isolated their peripheral blood monocytes and then stimulated them briefly with P. acnes, and then looked at both their cytokine production and then also levels of toll-like receptors on their surface.
And this was done in acne patients who were going to go on isotretinoin. Did you compare it at all to people without acne to see how their monocytes respond to P. acnes?
We did. We also recruited a group of healthy individuals who do not have acne and have also never taken isotretinoin. So we were able to compare them to the acne patients as well.
So if you, for now, just forget about the isotretinoin treatment, and if you looked at the cytokine response in the patients with acne compared to those without acne, did you get any differences, like at baseline, between acne patients and normal subjects?
We did. There was a pretty dramatic difference between acne patients and normal subjects. Acne patients' peripheral monocytes produced a lot more inflammatory cytokines than patients without acne. Their peripheral monocytes did not produce as many inflammatory cytokines in response to P. acnes.
So this is similar to what the published study showed then, that patients with acne, for whatever reason, seem to mount more of an immune response to P. acnes compared to those without acne. Were there any differences if you just drew, say, serum cytokine levels between the acne patients and the normal subjects? Were there any differences? Like, could the acne process the inflammation in the skin actually have some sort of effect on circulating immune system?
We did look at serum cytokines. Interestingly, we did, in terms of inflammatory cytokines, we did not see any difference between acne patients and people without acne. That was interesting because there are some skin diseases in which you do find elevated levels of inflammatory cytokines in the serum. The one difference that we did find was that acne patients appeared to have higher levels of IL-10 in their serum, which is an immunosuppressive cytokine. So that was a very interesting find, that perhaps they're already mounting a suppressive immune response in a way.
So they're sort of trying to fight off the inflammation by making more of the IL-10 that downregulates inflammatory responses?
That is one possibility, yes.
Okay. Now, getting back to the isotretinoin, what did you find in terms of the patients on isotretinoin? What happened with their immune responses?
Well, during isotretinoin therapy, acne patients' monocytes produced lower levels of inflammatory cytokines in response to P. acnes, and also at a basal unstimulated level. And this decrease in inflammatory cytokine production actually continued throughout therapy. So we actually saw a decrease in as little as 1 week of isotretinoin therapy, and it continued to decrease through 20 weeks of isotretinoin therapy. And the most interesting aspect is probably that their levels of inflammatory cytokines produced by their monocytes were actually, in a way, normalized. So by 20 weeks of isotretinoin therapy, their monocytes were producing the level of inflammatory cytokines as healthy non-acne subjects.
That's interesting. Now, there's been a lot of work talking about the role of the toll-like receptor 2 in acne. A lot of the work that Jenny Kim has done has shown that the inflammatory cells within acne lesions themselves express higher levels of TLR2, toll-like receptor 2. Did you find any changes with toll-like receptor 2 in the isotretinoin patients?
I did, actually. In my study, I found that isotretinoin actually decreased surface expression of TLR2 on patients' monocytes. And again, we saw a decrease in as little as 1 week, and that decrease continued through 20 weeks of therapy. And go ahead.
Now, these monocytes, these are like the circulating monocytes, so it's not necessarily the monocytes in the skin. So this is sort of a systemic effect that you think that the drug was having.
It is definitely having a systemic effect. The next step would be to see if it also has an effect in the skin. Patients take so much isotretinoin, their serum levels of retinoids are so high that my hypothesis is that you would see effects in the skin just like you see in the periphery. For this particular subset of patients, we only took peripheral samples, but it would definitely be interesting to see what was happening in the skin microenvironment.
Yeah, that would be very interesting. Now, one of the things that puzzles all of us is, you've shown, you're saying that your experiments are showing that even during isotretinoin treatment that there's downregulation of cytokines made by monocytes, and there's downregulation of the expression of toll-like 2 on the surface of the skin. But one of the questions that we as clinicians have is, any of the work that you've done, has there been any information on what causes isotretinoin to have a long-term effect on acne? Any thoughts or ideas on that?
So the long-term effects of isotretinoin are really not understood, as you say. So I was wondering if perhaps the decrease in TLR2 and the decrease in inflammatory cytokine production was a long-term effect or a short-term effect. And so I actually was able to recruit patients back about 6 months after they stopped isotretinoin therapy. And at 6 months post-therapy, their TLR2 levels were still way downregulated, and the levels of inflammatory cytokines that their monocytes produce in response to P. acnes were also still downregulated at about to the levels of where they were during their therapy.
So even 6 months after the patient stopped the drug, they still had the suppression of toll-like receptor 2 and inflammatory cytokine production.
They did.
Yeah, that's fascinating. Have you presented any of your work anywhere at scientific meetings or what?
I have. I've presented a poster at the Montana Symposium of the Biology of the Skin. Mm-hmm. I also presented a poster at the American Association of Immunologists meeting.
Oh, that's fascinating. And I'm sure you'll be working on writing your paper up and submitting it for publication.
Yep.
Can you tell us a little bit about your career plans and how support from the American Acne and Rosacea Society has helped you?
The American Acne and Rosacea Society has provided for my project, really enabled me to follow my instincts and to really test the hypothesis that that I wanted to. It was a very expensive project. I was using a lot of fluorescence-conjugated antibodies, which are very costly, and the support that the American Acne and Rosacea Society gave me really allowed me to fully explore the TLR2 expression and the inflammatory cytokines in enough patients where we could make conclusions. And as far as career goals, I really have fallen in love with immunology as a field. So I would like to stay in immunology, I think, for research. I will be completing my medical school degree in 2 years, and then hopefully I will stay in academia doing research as well as seeing patients in a clinic setting.
Well, thanks. That was wonderful, and congratulations on your studies, and we look forward to seeing the publications, and we appreciate your time. Thank you.
Great. Thanks for having me.